Good afternoon, everyone. Happy New Year, and welcome to our first Yale Sleep Seminar Series for the spring semester 2024. My name is Ritika Papa, and I'm one of the faculties here at Yale. And before I introduce our today's speaker, I'd like to make just brief housekeeping announcements. Please take a moment to ensure that you're muted. In order to receive the CME credit for attendance, please see the chat room for instructions. And if you have any questions or comments during the presentation, please use the chat room, or you can also unmute yourself at the end, and I will moderate the session. Recorded versions of these lectures will be available online within 2 weeks at the link provided. All right, and on to our presentation today. So I have the pleasure of introducing our very own faculty, Dr. Brian Koo. Dr. Koo received his medical degree from Tufts University School of Medicine. He completed his neurology residency from Long Island Jewish Hospital and clinical fellowship in sleep medicine from Cleveland Clinic and research fellowship from Case Western Reserve University, where he also served as a faculty for a few years before moving to Yale. Dr. Koo is a physician scientist, associate professor of neurology at Yale, and an internationally known expert in sleep-related movement disorders. He's also the director of the sleep lab at the Connecticut VA healthcare system and the director of the Yale Center for Restless Leg Syndrome and RLS Foundation-sponsored Quality Care Center. His primarily clinical and research interest lies at the intersection between neurology and sleep medicine, and is particularly interested in RLS and RBD and conducts patient-oriented clinical research to determine the underlying pathophysiology of these disorders. He's an international expert in the diagnosis, treatment, and investigation of restless leg syndrome and treats patients with RLS from across the tri-state area. And that's what we do too, refer all our patients to him. Currently, Dr. Koo's work focuses on assessing the role of the pro-biomelanocortin-derived neuropeptides in RLS and the role of autoimmunity in REM sleep behavior disorder. He's lectured courses in sleep disorders nationally and internationally. He's also a recipient of several awards and has authored over 50 publications, including various practice guidelines that we use on RBD and RLS. Dr. Koo has also held leadership position in many national societies. Thank you so much for being with us, Brian. And without any further delay, I would like to hand it over to you to share your expertise on REM behavior disorder, phenoconversion to synucleinopathy, and potential role for autoimmunity.
Thank you very much, Sheree, for that very nice introduction. I think it's recorded, so I may play it for my mother. So thank you.
Please go ahead.
Okay, so here is the disclosure slide. I don't have any relevant financial disclosures to tell you about. If you'd like to receive CME credit, you could text that number to the Yale CME line. So the outline, I'm going to touch briefly on the clinical entity of REM behavior disorder, how to diagnose it, what the PSG signature of RBD looks like, a little bit about screening and epidemiology, a little bit about pathophysiology, and then I'm really going to tie it to Parkinson and synucleinopathy, talk about what degenerative disorders in particular it's associated with, the mechanisms joining RBD and synucleinopathy, then talk a little bit about the premise for a research project that I have the very good fortune of being involved with. Okay, so it was not very long ago that REM behavior disorder was first described. It was in the mid-'80s by Carlos Schenk and Mark Mahawald from the University of Minnesota. And I think that this abstract is very elegant because it really highlights the quintessential parts of REM behavior disorder. So I'm not going to read the whole thing, but I'll highlight aggressive behaviors during sleep. Polysomnography did not detect seizures, but did document a variable loss of chin atonia, increased REM ocular activity and density. There were hand motions, reaching, searching, punches, kicks. It was associated with olivopontocerebellar degeneration, something associated with MSA, multiple system atrophy, atypical dementia. It was suppressed by clonazepam. And they described this as another category of parasomnia. And then interestingly, they referenced the work by Juvet, where he lesioned brains of cats and observed dream and active behavior. We'll look at that in a bit. But really an elegant an elegant abstract, and really has a lot of the features in that abstract which we use to diagnose RBD. So, the most obvious thing is the history, because it can be very dramatic. There can be a lot of violent behaviors that occur in sleep, so literal acting out of dreams, vocalization, complex behaviors. We like to use the PSG to either document this behavior or at least to demonstrate the PSG signature of REM behavior disorder, which is the REM sleep without atonia, or RSWA or RWA. And of course, that the disturbance is not better explained by another sleep disorder. So, this is what one would see in a PSG, more so on the left side. The left side, you see, I think you can see my arrow. So this is EOG, which displays a rapid eye movement. This is EEG, which demonstrates the low amplitude mixed frequency EEG that's characteristic of REM sleep. And this chin EMG, you see a lot of EKG artifacts, so you could just disregard that. But you see pretty low signal there, and also in the leg EMG that is consistent with normal atonia of REM sleep. So this is an epoch in REM sleep of someone with probably REM behavior disorder. And in the lower channels, you see various leads for EMG. You see chin, you see this anterior tibialis that is very customary during PSG. Then you see other arm leads. But what you clearly see is an elevated EMG in not only the chin, but in arms, and a little bit less, to a less extent, in legs. So this is this signature of loss of REM atonia. Here's another example. This is from our lab at Yale. You could see this is a 30-second epoch where you could see the rapid eye movements, the characteristic EEG. In the chin EMG, you could see clear increase in tone, which actually you see a little bit here in the right leg, but you don't see it in the left leg. But you could see how, one could potentially miss this if you don't have multiple EMG leads, which we don't. But here you see that. So in REM sleep is divided into tonic REM and phasic REM. So phasic REM is when you see mostly the phasic eye movements characteristic of REM sleep, and the tonic REM is in between those phasic events. And so an epoch of REM with at least 50% duration, the epoch having chin EMG greater than a non-REM sleep, is characteristic of increased tone in tonic REM sleep. And for phasic REM sleep, you're supposed to divide the epoch into these 10 3-second mini epochs, which I don't know anyone that does that clinically. But if you have 50% or 5 of these or more that contain bursts of increased EMG tone in phasic REM sleep, then that's characteristic of REM sleep without atonia. So not all behavior is violent. The violent behavior is what really gets, what most often brings people to our attention, because it can lead to injury and it scares, the bed partner and such. But, not everything is violent. So I'll play this for you. And I think most people could kind of tell what he's doing. So I'll just tell you, it looks he's smoking a cigarette. He's very relaxed, certainly not violent. And then there's going to be another video soon. This is very difficult, but this person, because they woke the people up right after they were acting out, they asked them what they were dreaming about, and this gentleman was eating a fictitious soup. Okay, so this was an article that was published in Neurology. I don't have the year, but it was probably more than 10 years ago. And you can see quietly eats and swallows a fictive soup. This person bought a bike. This person was picking apples and grabbing her husband's head. So kind of funny acting out. Okay, so this is something I got over YouTube, and I'm sorry it is a little bit grainy, but you could see the person is starting to move. The R stands for it was scored as REM. And now you can see clearly the movements are punching. I mean, they're very purposeful. It's not just it's not just general flailing. It's very specific and is punching. So this we saw already. So often the history is clear, and so you ask for episodes of acting out. But sometimes, especially, I practice a lot of my sleep medicine at the Veterans Hospital in West Haven. And so it can be very difficult to distinguish kind of non-specific um, kind of flailing associated with PTSD versus true REM behavior disorder. And sometimes it's impossible to do that. But what I've found is that the gentlemen that have acting out associated with the PTSD are less likely to kind of recall a time when they woke up in the middle of punching and they remember dreaming. That seems to me less likely to occur in PTSD than it does in REM behavior disorder. So I always ask them if they remember something like that. But even those with REM behavior disorder, not all of them remember. And you have to also recall that many of these people with REM behavior disorder are cognitively impaired. So they just might be amnestic for that. So sometimes I will ask them, you may not remember the dream now, but the moment you woke up from in the middle of acting out, did you remember dreaming about something vividly? And sometimes that will, even if they can't recall what they were dreaming about in the clinic, they can say, yes, at the time I do remember. But other kind of pearls, we talked about the recollection, falling out of bed. Usually adults don't fall out of bed. So falling out of bed is fairly somewhat specific to REM behavior disorder, injury to self or bed partner, violent action-packed dreams, and a lot of talking and yelling. Okay, so we went over the diagnostic criteria, but there are a number of screening tools which one could use, especially in a research study. This is one of them, the REM sleep behavior disorder screening questionnaire. This is a German questionnaire, and it has 13 questions because I think this one has like 3 parts. And it's pretty sensitive, although suffers a little bit of specificity if they answer 6 or more of these as affirmatively. What I found a little bit odd about this question doesn't actually ask them if they act out their dreams. It says, that has very vivid dreams, it has aggressive or action-packed content, but nowhere does it ask them if they act out their dreams, which I found a little bit odd. But I think this is a single screening questionnaire, which was developed by Ron Postuma, which I think is a great question. So the question is, have you ever been told or suspected yourself that you seem to act out your dreams while asleep? For example, punching, flailing your arms in the air, making running moves, etc. So this single screening questionnaire supposed to have 94% sensitivity and 87% specificity. I'm a little bit dubious that it has that high sensitivity and specificity, but I think if you combine these two, then you're really going to have good specificity and maybe sensitivity. So the true prevalence of RBD is not really known, but it's thought to be about 0.5% in the general population. There was a study in Korea which looked at video PSG. And this, you have to remember that these are people that were, studied that had a sleep problem. So this prevalence is probably a little bit inflated. And they found a prevalence of about 2%. In the elderly population, it increases significantly because older people are more likely to develop this. We'll talk about why, but about 5 to 13% of people between 60 and 100. Male predominance, and a strong link between, should say, neurologic and psychiatric disorders. We'll talk about that in a little bit later. So we'll talk about neuroanatomy. I think this slide might give some people PTSD and perhaps some of my pulmonary sleep colleagues more so than my neurology sleep colleagues. But So the neuroanatomy of sleep has been very well worked out. And so the REM center is a cholinergic center in the pons, the pedunculopontine tegmentum and the lateral dorsal tegmentum. So during REM sleep, this area is very active, and um, it it connects to excitatory neurons that run through the pons, through the medulla, and then onto an inhibitory interneuron, which then synapses on the alpha motor neuron. So this is kind of the neuroanatomical basis of REM sleep without atonia. So we're paralyzed because of an eventual inhibition of the alpha motor neuron. And so, whoops, sorry, when one has a lesion of this pathway, that's when you would get loss of REM atonia and possibly REM behavior disorder. So I'm sorry, you might not be able to hear my, are you able to hear that? Did you hear that weird music or no?
Yes.
Oh, you did?
Yes. Yep.
Oh, good. Okay, so these are the studies by Jouvet, and they came out in the 70s. So this video comes with this very strange psychedelic music. So I hope you enjoy it. So we'll play it.
This remarkable film shows a cat in the middle of a night's sleep. Now, believe it or not, the cat is still asleep, but because some of its nerve pathways have been cut, it's acting out its dream. Normally, when we dream, we're effectively paralyzed from the neck down, but that paralysis has been bypassed in this cat. Its brain shows all the signs of REM sleep, but its muscle activities suggest an exciting dream life chasing flies and mice. If our muscles weren't paralyzed, we too would probably act out our dreams in this way. Perhaps it's fortunate for our partners that we don't.
Yeah, so I thought this was it was very funny that the original Schenck abstract referred to Jouvet's study, and this is a video. I don't know if Jouvet, I didn't read this article. I don't know if he referenced, humans would act out dreams, but at least the video does. So I thought that was pretty entertaining. Oops, sorry. Okay, so this is a follow-up study to the original RBD cohort. It's a little bit expanded to 96 patients. You can see that of the 96 patients, about 40% had isolated. I mean, I think you could still call idiopathic RBD, but some people now prefer the term isolated RBD, whereas about 60% had other medical or psychiatric disorders. About half of them had central nervous system disorders, many of them degenerative disorders that included dementia, Parkinsonism, OPCA, Scheidrigger, which are kind of on the multiple system atrophy spectrum. So, these are important because the Lewy body, the Parkinson's disease, and the multiple system atrophy are all synucleinopathies. It is also important to note that a lot of the patients had narcolepsy, and I think this is an important, clinically, very important important association, because if someone has narcolepsy and they have dream enactment, then you should not be telling them that they have increased chance of developing Parkinson's because their dream enactment is part of their narcolepsy. I mean, they could be very unlucky and have both diseases, but I've had a number of patients that have been told, oh, you're going to develop Parkinson's disease when they have narcolepsy. And I tell them, no, that's not true. And they're very relieved. So just remember that. You can have vascular disorders and have it, multiple sclerosis, another. If you have someone with MS that has dream enactment, I also would not tell them that they have an increased chance of Parkinson's disease, because they can very well have lesions in the brainstem that cause that. This slide just kind of highlights this synucleinopathy, Parkinson's, Lewy body, multiple system atrophy, pure autonomic failure is kind of on this multiple system atrophy spectrum. PSP, ALS, and Alzheimer's disease are what we call tauopathies. So they have an abnormal accumulation of the tau protein in the brain. They can be associated with REM behavior disorder, but they are much less so than the other things. And so that, for the fellows, is often a board question. You have to remember what the tauopathies are, the Alzheimer's, ALS, PSP, and what the synucleinopathies are, idiopathic Parkinson's disease, Lewy body dementia, multiple system atrophy. Again, you could see narcolepsy, you can see it in PTSD, demyelinating disorders, limbic encephalitis, stroke. I mean, I think it would just have to be very, very, I guess, it's pretty common to have brainstem infarct. So, but these latter four, if you have someone that has acting out of dreams, then I certainly would not tell them about the association with Parkinson's disease. There's also an entity called pseudo-RBD, in which somebody with untreated sleep apnea can have dream enactment. I think this is much more the case if you have severe apnea during REM sleep. So this is a 30-second PSG epic, which shows, rapid eye movement, the characteristic EEG, and then you see an apnea here, which causes an arousal. And, if you have an arousal in REM sleep, then you could certainly start acting out. So, if they have sleep apnea, it's important to treat it to make sure that that it's not solely due to the sleep apnea. The caveat there being, even if they have true idiopathic REM behavior disorder, untreated sleep apnea can increase the frequency of the dream enactment, but it often does not go away with the treatment of sleep apnea. It might just reduce the frequency, but it usually does not go away if they have true REM behavior disorder. And then there's this question of, antidepressant usage. So this is an interesting study which just took normal individuals and that were being started on sertraline. And you can see at baseline, they had very low percentages of RSWA, but it wasn't zero. So, 3% had REM sleep without atonia, in tonic REM sleep, 3% in phasic. And then, they were put on a low dose sertraline, and then it was increased over the course of a couple of weeks or so. And you can see that these percentages just increase. So by, month 2 or so, on the order of 12 to 15% had REM sleep without atonia. So while you can get dream enactment from being on an antidepressant, you also have to be careful because antidepressants are so commonly prescribed and used, and you have to remember that people with eventual Parkinson's disease are going to often be depressed. So, many think that this dream enactment associated with antidepressant usage, the people, the antidepressant may have just brought it out in people that are destined to actually progress to synucleinopathy. So, it can be totally isolated, but it certainly can be kind of a phenomenon where, you just introduce this and you're bringing out something that's eventually going to appear. Okay, so, we've been alluding to this phenoconversion. The study by far that describes this in most detail with the greatest number of cases was led by Ron Postuma and included many centers across the world and had, almost 1,300 patients with isolated RBD. So this was, I think, Asia. I'm not sure if it's Asia, but it's certainly Europe and North America. I'm trying to look if there are any Asian names here, and I don't necessarily see. But these are all confirmed with PSG, having REM sleep without atonia. They were about 66 years old and predominantly men. And they were followed for about 5 years, but the follow-up really ranged. And you could see that in this Kaplan-Meier curve that over the course of about 12 years, about 74% of them phenoconverted to a synucleinopathy, so very high rate. And I think if you go to 15 years, it's closer to about 90%. And this is what which interests so much of us in this field. This is a busy slide, but I think it's important to kind of go through. These are the different factors. So in this study, what they did is they had all these patients with isolated REM behavior disorder. They followed them for several years, and then they standardly assessed them for different things like motor function, quantitative motor testing, olfaction, color vision, assessed their, whether or not they had constipation, erectile dysfunction, and so forth. And so you could see that the things that were most predictive of phenoconversion were an abnormality in the Unified Parkinson's Disease Rating Scale, the Part 3, which is the motor exam. So not surprisingly, if you had an abnormal motor exam at some point, you're very, very likely, you're fourfold more likely to phenoconvert. If you had quantitative motor abnormalities, same thing. Even if you had in the UPDRS experiences of daily living, motor abnormalities self-reportedly, you were also had a very high hazard ratio of phenoconverting. Olfactory abnormality was associated, color vision associated, insomnia not, sleep apnea not, erectile dysfunction, constipation, REM percentage above mean, yes. Surprisingly, orthostatic symptoms not. So you can and cognitive dysfunction, yes. So you could see, and not surprisingly, an abnormal DAT scan, yes. So you could see, all these different factors, and what one can do is you can kind of calculate the risk of phenoconversion, the baseline being the presence of isolated REM behavior disorder, and then you could kind of, through some sort of calculation, add in these other factors and then come up with a likelihood of phenoconversion. This is another study by Posthuma, which looked at about 150 patients with isolated RBD, followed them up for between 2 and 12 years. And the take home is that, so I'll direct your attention to panel A, which was all of these 154 people with RBD. So they could have gone on to have Lewy body, they could have gone on to have Parkinson. But what you saw early on was olfactory abnormalities, then color vision, and then constipation. And it wasn't until later that you began to see motor signs. And so in panel B, it divided this cohort into those that eventually converted to Parkinson's disease. So it took out the Lewy body people. And you could see that there was a lot of overlap between the two curves, but there are some differences. So hyposmia occurred early, like in all RBD, the all RBD population, the REM atonia next, the erectile dysfunction next, colored vision and constipation. And again, it wasn't until very late that the motor signs of Parkinson's occur. And, by convention, the diagnostic criteria for Parkinson's can only be fulfilled when the motor signs are either seen or occur by history. And so, based upon this curve, some of these prodromal symptoms can precede the motor onset by decades. And so this gives us a very kind of wide window in which we can identify people and hopefully at some point give them something to decrease the risk of phenoconversion. And so this is what many people are interested in, including our group, and what we're going to talk about a little bit here. So kind of shifting to more of the Parkinson's pathology. So in Parkinson's disease, there there is a physician scientist by the name of Brock who proposed that Parkinson's pathology can often start in the gut, make its way to the brain, and then affect the lower brainstem, and then travel up the brainstem and into the brain. And so what is thought to happen is that, depending on genetic predisposition and potential differences in microbiome in the gut, you'll have this expression of abnormal expression of alpha-synuclein, which aggregates and leads to some pathologic process. And this pathologic process could actually travel up the vagus nerve, and the vagus nerve has its nucleus in the medulla, and so that's why the lower brainstem, that's why the lower brainstem is affected. And then by kind of local travel from the lower brainstem to the middle brainstem, the pons, and then to the upper brainstem. So remember, the upper brainstem or the midbrain is where we think of as being the signature pathology of Parkinson's disease, is where the substantia nigra lives. So it's not until the disease process gets all the way up there that you begin to see signs of motor Parkinson's disease. And this, based upon the clinical experience we have, can take decades. So this kind of body first, there's also something called brain first, and you can see that there are some signature differences, but the body first, you have RBD, you have anosmia, you have a faster cognitive decline, motor symptoms are more symmetric, and so the opposite for brain first. Okay, so we talked a little bit about this alpha-synuclein. So alpha-synuclein is a neuronal protein which regulates synaptic vesicle trafficking and neurotransmitter release. So what can happen is it can tangle and aggregate. And so once it aggregates, it can form, it looks kind of nice and pretty, but it's not nice and pretty, I don't think, when it gets into the brain, because what happens is so this is a picture of a neuron. It takes up space, it pushes things out and leads to kind of cell death. And this again is this progression, which is occurring, vagus nerve coming up, then up through the brainstem. And so we talked about the formation of Lewy bodies, and this is just a cross section of the midbrain. And so remember that substantia nigra literally means black substance in Latin, and this black substance, this substance is black because of the dopaminergic neurons consist of a lot of neuromelanin, and the melanin is what pigments this area. And in Parkinson's disease, you have a death of dopaminergic neurons, and then you have something that looks like this, and then you get Parkinson's. Okay, so I guess the question is, so why does this occur? So there's evidence that there are these Lewy bodies and like this aggregation of alpha-synuclein in the brain, but how does that lead to neuronal death? So this is a study that looked at post-mortem brain samples of people with PD. You can see controls, and in PD, here they stained neurons as this brown, and then the blue stain was T cells. And you can see that there are many more T cells in the Parkinson brain, and many of these T cells were kind of abutting or touching dopaminergic neurons. And so this kind of suggests that there is an inflammatory process or an immune process that is leading to kind of cell death. This is an animal model in which there's an injection of a viral vector that leads to alpha-synuclein overexpression in the brain. And they compared this just to expression of non-pathologic other substance. And you could see that when they injected this alpha-synuclein and there was alpha-synuclein abnormally expressed in the brain, there was a much greater immune response. So IgG is stained in red, so you can see a lot of red in the cases that were injected with alpha-synuclein vector, as opposed to not much red when they were injected with this other protein substance that doesn't induce pathology. And so the numbers here show that, but kind of what's interesting here is kind of what we see clinically. I'll show you in a bit that early on you have kind of this large immune effect early on, first 2 and 4 weeks, and later on it kind of evens out, you have less. So I will, let's see. And actually this is the slide. And so this is a clinical translational study in which they took Parkinson's disease patients and controls, and they took their blood and they isolated their PBMCs, peripheral blood mononuclear cells. They cultured them, and then they exposed them to alpha-synuclein. And what they measured was kind of this response to this exposure to alpha-synuclein. They measured interferon response, interleukin response, any cytokine response, and you could see that in general, the patients with Parkinson's disease had a significantly greater or more brisk response than did the healthy controls. And I guess they had an Alzheimer's disease control too, which didn't have much of a response to alpha-synuclein. What was interesting and what kind of mirrors that animal data that I showed you is that the response was greater for those that were diagnosed more recently. So for those that were diagnosed within 10 years, any cytokine response was a lot higher than those that kind of had Parkinson's disease for 10, 20, 30 years. And you can think of this as kind of burned out Parkinson's, where they have already had significant neuronal loss and the damage has been done, and the protein exists in the brain, and the inflammation occurred early and is less so. So kind of armed with this background of a hint of an immune process in Parkinson's disease, Dr. Hafler, the chief of neurology here at Yale, he's a neuroimmunologist, thought that we know that RBD is associated with Parkinson's. RBD, in some cases, Parkinson's, is initiated by an autoimmune event involving alpha-synuclein in the gut, and the interactions among the immune system, the peripheral and central nervous system establish disease in the brain. And so what Dr. Hafler did, along with a team, which I'll show you in a second, is we proposed kind of a very large sweeping grant, which largely is based upon patient samples. And so we have these different groups. We have controls, we have isolated RBD, 2 groups of isolated RBD. We have a group of patients with PD and a group of patients with Parkinson's and without RBD. And we split it into kind of 3 different aims. So to take these samples from these patients, so to take blood and CSF from these patients, and to isolate the cells, the immune cells from these samples, and to look at DNA, RNA expression by single-cell RNA sequencing. Arm 2 was kind of to take the stool and to look at the metabolomics of the stool, the gut microbiome of the stool samples. At the same time, we had others in the group who would take these stool samples and implant them in germ-free mice and create a Parkinson's disease model, kind of do similar things to what we were doing in humans, looking at single-cell RNA sequencing and CSF and blood of these animals. And then finally, in another aim, we would get, we've gotten brain from patients that have donated their brains that had Parkinson's disease, look at different regions of the brain, and again, look for an immune signature, an interaction between the immune system and neurology. I'm sorry, the brain. So I'm largely going to be talking about kind of aim one, but you can imagine that this is a large amount of work. So there are a number of people involved. Dr. Xavier and Dr. Palm kind of leading the microbiome and the gut work. Rui Chang kind of leading the animal work and looking at the role of the vagus nerve and creating a Parkinson's disease animal model. Dr. Chandra helping with this effort as well with the animal model, but also looking at postmortem brain. And then Li Zhang doing the single cell RNA sequencing, David Van Dyke, a computational biologist, to help the genetic analysis, and then myself here and Jesse Cedarbaum kind of leading the clinical group, and then Nick really the project manager trying to coordinate all of these people. So you can see a large effort here. So we are kind of in, I won't say the middle, but we are. So I guess here's a slide. This is where we're at. So this is the clinical team. This is our coordinator, Kara Mead, Sapna Patel, Shreya Reddy, our postgrads, our excellent postgrads that have helped us recruit these patients. So we have about 68 patients. So this is our goal. This is where we are. 68 patients. They are largely homogeneous, but not completely. They're, in their 7th decade of life and predominantly men, but not universally men. And so, like I said, in aim one, we take the blood mononuclear cells, the cells from the CSF. We run them through this 10x genomics machine, and this technology, which I'm not an expert in, and I'll try to explain a little bit, but it is amazing technology where it actually, through this technology, can barcode each of these tens of thousands of cells and barcodes it, and then analyzes the DNA and can do DNA RNA analysis in each of the different cells, and then gives you that data. So that's why you need someone with expertise at David Van Dyke to help you analyze it, because otherwise you just have like tons of data and feel totally helpless. And so I'm not going to explain all that. It's like I cannot do that. But basically, what we found in our different groups, control RBD PD, and we collect a high volume CSF, 30 milliliters of CSF, and we count the cells in all of that 30 milliliters. And when Dr. Zhang does that, we see that there are an increased number of cells in RBD and even in PD. So, but certainly more in RBD, which again goes on, which is kind of consistent with disease being in the early process. Maybe there's more of an immune process. So this is consistent with that. So also with the single cell, so this is this single cell RNA sequencing, and you can see that each of these different cells has kind of a characteristic signal, and you can tell what these different cells are based upon its signature. And then if you do this for patient, and you split up the patients with RBD and those controls without RBD, you could see if there are differences in the types of, if there are differences in the quantification of these different types of cells. And here you say, there's kind of mixed, so you're not sure if there's a difference. Whereas in this, so this is controls in RBD, you could say, oh, there seems much more blue here, and there seems much more of this orange here, so maybe there is a difference, and then you can quantify it. So it turns out that black is control, white is RBD. There wasn't much of a difference at all in the CD8 and CD4 T cells in the CSF, but in the myeloid cell populations in myeloid cell 3, controls had more than RBD, but in myeloid cell 1, RBD had more than controls. So there does seem to be something going on immunologically. And then you could look for specific genes. And are these genes differentially expressed? And yes, they are differentially expressed. There's some that are upregulated, some that are downregulated in RBD. And then you do this complicated analysis. This looks for clonally expanded T cells, and here's RBD and here's control. And if you compare the two, just eyeballing them, yes, they look different, but how different are they? I'm not sure. But then you quantify, and yes, there seem to be clonally expanded T cells more so in RBD than in controls. So I've just given you a very high level because this is really, beyond. I rely on David and Lee to kind of try to explain this to me, and I try to learn as much as I can. But there does seem to be inflammation in CSF patients with RBD. The single cell RNA sequencing reveals inflammatory changes in CSF myeloid populations for RBD patients. I didn't show you this, but increased LRRK2 expression in RBD CSF myeloid cell population. And then there seems to be more clonally expanded T cells among the RBD population. So just as kind of a bigger summary, what I hope to demonstrate to you is that, RBD, it goes back to the patient. The clinical information is very powerful and is the absolute way in which we identify these people. So by history, by PSG, the symptomatology and progression to motor PD suggests brainstem disease. RBD is the single most powerful predictor of incident synucleinopathy and confers about a 50-fold increase incidence of synucleinopathy. There's immunologic data that should suggest that there is an inflammatory response to alpha-synuclein, perhaps in the gut and perhaps in the brain. And we're collecting evidence to suggest prominent inflammation, even autoimmune RBD. And this would provide a rationale to test immune-suppressing therapy in persons with RBD to try to prevent Parkinson's disease, or at least maybe slow the progression. So I'm very lucky to be involved in this very large effort to kind of try to iron out the pathophysiology and immune mechanisms underlying Parkinson's disease. We have identified a lot of patients. I think I said it was like 66 or something. We'd like to identify on the order of 100. So we're asking for people for their help. So we have increased our reimbursement so that we can reach out to people that are beyond kind of Connecticut. So I'm asking you, please. These are my kids asking you, please. And this is my cat. This is when she was first a kitten, so she's asking you, please. So, they at least have to be 40 years old. The big kind of things that can exclude them, they can't be on an antiplatelet agent other than aspirin because they need to have an LP. They need to be free of any immune-suppressing medications, and they do need the PSG that demonstrates the REM sleep without atonia. And this is just some of the things that that they would undergo. If you do have any patients, feel free to just pass them my way. You do not have to mention that they need to have a lumbar puncture. You can if you want to, but you could leave that conversation to us if you'd like. And for people with Parkinson's, because we're trying to get people that are more likely to have this immune signature, we're doing it for people that have been diagnosed within 10 years. And so, I wanted to end with the work that will likely start in a year or so, and it was kind of this research has provided rationale, but there are also other studies, retrospective, that suggest that immune suppression. So in this case, they took patients with inflammatory bowel disease. So inflammatory bowel disease is another kind of risk factor for incident Parkinson's disease. And they separated these people into people with IBD that were treated with anti-tumor necrosis factor therapy and those that were not. And when they did that, the people that were treated with an anti-tumor necrosis factor, and so table 3, seemed quite protected from developing Parkinson's disease. So you can see hazard ratio of 0.22 and a not that wide of a confidence interval, certainly below 1. So they seem very protected. And so because of this, what we are planning and in the planning stages of, and hopefully we'll start this within a year or so, is we are planning a neuroprotective trial using this anti-TNF alpha therapy to try to the endpoints are not completely sorted out. It may not be phenoconversion to synucleinopathy, but it probably will be some decrease in cognitive functioning measured by various scales and progression on motor scales such as EPDRS and other things. So this is another thing that we're planning and very excited about, and happy to take any questions. So this picture, I'm sure probably some of you recognize this because it is in the internet, but this is a gentleman that I believe was one of the part of the original cohort of Schenck, and he fashioned this harness during sleep so that he wouldn't get out of bed and injure himself. And so this is a picture of him with that harness.
All right. Thank you so much, Brian. Thank you so much for sharing that terrific work. Excellent presentation, and looking forward to the newer treatments that you guys might come up with for Parkinson's. It's high time. I had a quick question. So my question was to the part that you alluded earlier about the body first and the brain first kind of Parkinson's. So is there any, I'm not sure if I missed it, but is there any difference in the prognosis for these kind of patients and the type of communication that we should be doing in the sleep clinic before we send them to a neurologist?
I'm sorry, Sri, can you repeat that again? I got distracted because I stopped my sharing.
Oh, no worries. Did you also miss the excellent part that I mentioned? No, so my question was, the brain first and the body first Parkinsonism that you mentioned, is there any difference in the prognosis, the type of conversation that we should be having with these kind of patients, the difference before we send them to their neurologist, to the neurologist?
Right, there is difference. I think that with the body first, there was a faster cognitive decline, and that kind of goes along with RBD. People with RBD tend to have a cognitive decline, and I think the motor symptoms do progress differently. But I certainly wouldn't expect a non-neurology sleep doctor to be talking to patients. I myself do not feel comfortable with that. That needs to come from a movement disorder specialist. And so, yeah, but I think I'm not sure of. Yeah, I mean, it is a good question because if one has REM behavior disorder, it's progression to synucleinopathy, but we're all guilty of just kind of focusing on Parkinson's disease. Even as a neurologist, I kind of do that. And sometimes, to be more simplistic, when you talk to patients, you talk to them about Parkinson. But, they are definitely at risk of developing Lewy body dementia and multiple system atrophy. So I think it's fair to include that in your discussion. Many patients are aware of these associations with dementia. They'll just say, yeah, I know it's associated with dementia and Parkinson's disease, and that's true. And so I think it's fair to talk to your patients about that.
Thank you. I have a question here by Parvati. Number one, if you see PLMS in REM sleep without dream enactment behavior, can you call the leg movements as REM without atonia as well? And then number two is, if someone is taking melatonin and having frequent symptoms of possible dream enactment behavior, would you hold the melatonin for the night of the PSG?
Right, right. Well, it's a good question because, in fact, one of our fellows, Matt Ballenberger, is going to be doing a research project looking at PLMs during REM sleep, and has been described that PLMs are more likely to occur in REM sleep for patients with RBD than not. However, I don't think that PLMs during REM sleep in isolation are the same thing as loss of REM atonia. These are different phenomena. The pathophysiology is different. So while it is kind of one can, it's kind of what am I looking for? What word am I looking for? Well, you may be tempted to say that because sometimes you don't see the REM sleep without atonia, but you have the clinical history. It's kind of tempting to say, oh yeah, that's what it is. I wouldn't do it. For the research study, I'm very strict with that. I see these PLMs, I'm like, I see the PLMs, but I don't call that REM sleep without atonia. And then the second question, melatonin. Yes, if they're on melatonin, I do hold that on the night of their sleep study. I might tell them to hold it for like 2 days, before the night before the study and the night of the study.
Perfect, thank you. Another question by Toshiba Kumar. Should I refer these patients as a non-neurosleep to a movement disorder specialist or to a neurologist? And should I monitor with the Lewy body composite score or a Parkinson's score? And what about geriatrics referral?
Yeah, I think that it's very fair to refer them. But I think as a non-neurology sleep specialist, you could also simply have kind of a list of questions you could ask them. So you'll ask them if they have tremor, if they have any slowness of movement, rigidity, and then ask them about constipation, urinary dysfunction. Do they have lightheadedness when they stand up? So, because sometimes you have patients that have absolutely nothing. They don't have anything other than dream enactment. And, while your neurologic exam is not going to be as thorough and as nuanced as a neurologist, if they have absolutely nothing and they walk and they look very normal, and then you check for their tone, they have nothing, I think it's fair not to. But if we look at them and they have kind of a blank face and they maybe have some symptoms, I think also it's very reasonable to refer them. But what I would say is that I would do the sleep study before kind of talking to them, I would do the sleep study, looking for the REM sleep without atonia, and then kind of have a conversation. You may want to see a neurologist, so on and so forth. Mm-hmm.
Perfect, thank you. And the last question I have here is from Andre. Great job, Brian. Thank you. Can you remind us the mechanism of action of melatonin in RBD?
That's a good question because, yeah, I mean, it's interesting because in Schenk's original abstract, he referenced disipramine, and I remember as a sleep fellow thinking, even for REM-related obstructive sleep apnea, yeah, if you just give them a REM suppressant, it should help, right? And the same thought could be about RBD. If you suppress REM, then they're not going to be in REM. So, melatonin, the precursor is tryptophan. So it's kind of, I think of melatonin as kind of somewhat serotonergic, and maybe by that way it suppresses REM in some way, perhaps. And I think that could be the mechanism, but I could be wrong. But that's how I think of it.
Along the same lines, Brian, how do SSRIs suppress REM but also cause RBD?
Well, so remember that in REM sleep, you will have very, very high cholinergic tone, right?
Yeah.
And then in REM sleep, you have very, very low serotonergic tone and very, very low adrenergic tone and somewhat low histaminergic tone. So if you increase serotonin, that's why it's REM suppressing, because you're supposed to have very, very low serotonergic tone during REM sleep. Yeah, so that's why it suppresses REM sleep. But, you know, it can also increase REM sleep without atonia. Yeah.
I'll pick your brain later. I have another question from Stuart Hoffman. There are lots of patients already on immunosuppressants. Would a case control study be of value?
Yeah, I think it certainly would be. And you know, you saw kind of one in this IBD population, but if somebody wanted to do a case control study with people with idiopathic RBD, maybe a good study would be looking at people with psoriasis and you know, going to a dermatology clinic and simply giving them the questionnaires that I showed you to screen for RBD. Now that would be a good study. Um, um, so yes, I think that would have a lot of value because I don't know of any other studies besides the one I showed you that, I could be wrong, but yes, I think there would be great value in doing studies like that.
I don't see any further questions. If anyone has any more questions, feel free to ask, or else we'll end it here. All right. I
Thanks
don't
very
see
much.
any. Thank you. Thank you so much, Brian, for this great talk. Thank you, everyone, for joining, and see you next week. Bye-bye.
Bye-bye.